Leukemia in Pediatrics by Jessica Anderson. Acute leukemia is the most common form of cancer in children. It accounts for approximately 30% of all childhood cancers. There are two types, acute lymphocytic leukemia, also known as ALL, and acute myeloid leukemia, AML. ALL is more common in children and accounts for approximately 80% of new cases. Most of those cases are in the age range of 2 to 6 years old. AML is less common and only accounts for approximately 15% of cases in children, and approximately 90% of children diagnosed with ALL can recover. A study was conducted by the Centers for Disease Control and Prevention. It took a look at the years between 2001 and 2014. It tracked pediatric leukemia cases, specifically ALL, and the incidence of that was 34 per 1 million persons. Those rates were highest in the children age groups of 1 to 4. The incidence was 75.2 cases per 1 million and seemed to show a higher rate in males versus females. Studies found among racial and ethnic groups that the Hispanic population had a higher rate than non-Hispanics. The rate was 42.9 cases per 1 million versus 34.2 cases. The overall 5-year survival rate for ALL is approximately 90%, which is really, really great. Most of those can be cured, and children are considered cured after 10 years of being in remission. AML has made a lot of progress. It's still at the 65 to 70% range of an overall 5-year survival rate. Just keep in mind, kids in higher risk groups and other subtypes of the disease can alter those. So looking at our high-risk populations, the majority of leukemia cases have no known cause, but some incidence has been linked to environmental or genetic risk factors. Some of those have shown links between advanced paternal age and maternal fetal loss. Other studies have shown certain genetic syndromes such as Down syndrome, neurofibromatosis, and Bloom syndrome can increase risk factors for developing ALL. So looking at the pathophysiology of ALL and AML, ALL is usually composed of immature B and T cells called lymphoblasts. The normal bone marrow becomes disrupted and replaced with the lymphoblasts, which causes disruption of normal function. In AML, it is caused by acquired oncogenic mutations that results in the accumulation of immature myeloid blasts in the bone marrow. These blasts crowd out the marrow and cause marrow failure and complications such as anemia, thrombocytopenia, and neutropenia. Signs and symptoms of leukemia can include anemia, pallor, listlessness, irritability, chronic fatigue, history of repeated infections, some bleeding episodes such as those nosebleeds that just keep occurring, petechia or hematomas, extreme bone and joint pain. We can see lymphadenopathy or hepatosplenomegaly with leukemia. Hepatosplenomegaly is the most common finding, and it accounts for about 64% of cases. A lot of times these kids can have some anorexia, weight loss, abdominal distension, or abdominal pain. Noted with this, lymphadenopathy is present in nearly half of children with ALL. Fever is also present. It can be present in more than half of children at the time of diagnosis. The fever itself may be caused by infection, or it can just be a constitutional symptom caused by the leukemia itself. Hematologic abnormalities are common. We're looking at those platelets. White blood count are often altered in these patients, and just musculoskeletal pain is a presenting symptom in approximately 43% of cases. Young children with bone pain may come in with a limp or unable to bear weight. So those are things to be looking for. The diagnostic evaluation that would be needed for those kids with suspected leukemia would be a CBC with differential, looking at our white blood count, platelets, reticulocyte count, keeping in mind that WBC count may be elevated, normal, or low with varying levels of neutropenia. We want to go ahead and get coagulations, looking at those prothrombin times, partial thromboplastin times, fibrinogens, things like that. Chemistries, want to look at our electrolytes, renal and liver functions, lactate and uric acid. Also, we would need a LP and bone marrow aspiration at some point. X-rays, CTs, ultrasound, MRIs, all may be part of the diagnostic evaluation of this patient. There are so many psychosocial implications that can arise from a new diagnosis of cancer. Fear of the unknown, fear of death, just fear of what the patient has to go through, especially as a parent myself, just all of those anxiety related feelings due to the loss of control over the situation. There's financial burdens. Often, parents have to be uprooted from work to be able to go sometimes to different cities to be able to get treatment for these cancers. These kids are away from all of their family members, their friends, school, all of their normal activities. Depending on the age of the patient, there could be, especially in the teenage years, self-esteem issues and not feeling like other normal kids. So those are just a small amount of the psychosocial implications that can arise from a cancer diagnosis. So what is the nurse practitioner's role in all of this? And I think the biggest thing is just facilitating proper referrals for effective interdisciplinary care. It is important that these kids maintain regular health visits, but we need to be very conscientious to work with oncology to know when we should send the patient for further testing or evaluation. Providing resources for the family for emotional and physical support. As I discussed earlier, there's going to be so many psychosocial impacts for the family, for the patient, that we just really need to be there as a resource to give them comfort during this time. Just a few things to consider when talking about immunizations. Patients who are specifically getting chemotherapy, things like that, should only receive inactive immunizations during chemotherapy. Those live virus vaccines like MMR, varicella are contraindicated, but it's just really important to be on the same page and in communication with oncology to kind of go by what they suggest. Also, there are some other risk stratifications when we're talking about ALL and AML. There are low risk category. Those are children with a favorable age. They have a low white blood count and favorable cytogenetic change. Our standard risk are children with a favorable age, low white blood count, and favorable response to treatment, but may not have that favorable cytogenetic changes. Our high-risk population, in which I thought this was really sad, is patients older than 10 years of age with a diagnosis that has unfavorable cytogenetic changes and with a measurable disease. Some of the support groups and referral sources I have listed are the Leukemia and Lymphoma Society, Cancer Care, American Cancer Society, St. Jude Children's Research Hospital, TNK Children's Foundation, and Childhood Leukemia Foundation. So the discussion question I have for you actually comes from a real life case that I had back in January. So I'll go over the questions and then I'm going to kind of follow up a little bit more on this patient after I go through this. So the question is based on a 13-year-old boy presents to the primary care office in January with complaint of low-grade fever, muscle and joint pain. He has pallor and increased tiredness. It was the weekend, so mom takes him to the weekend clinic where a rapid flu screen comes back negative. The patient is sent home with a diagnosis of viral illness. Symptoms continue to worsen over the weekend. Mom brings him back to you on Monday. The patient is extremely pale, tachypnic, and oxygen saturation is hovering at 90%. What lab or diagnostic imaging, if any, would you perform on this patient and why? The CBC comes back because you chose to do that. The white count is 200,000. What is your next step as a nurse practitioner for this patient? And how would you, as a nurse practitioner, explain to the patient and the family what these symptoms and results could possibly mean? So here are the references for this. To go back to that patient did come in. Primary care did send him to the emergency department back in January. Basically, he had started on a Friday evening, just having fever, just kind of feeling achy, overall not feeling well. Mom ended up taking him to the weekend clinic on Saturday. As the discussion question talks about, they did a flu because it was in the middle of January, did a rapid flu screen on him. It came back negative. Just told Mom to continue with Tylenol, Motrin. Figured he had a viral illness, just to stay hydrated. Mom said on Sunday he seemed to be feeling a little better, just super tired, not really wanting to get up. By Monday, he still just was not feeling well, sleeping the whole day. Mom ends up taking him back to primary care, I think on Tuesday. It was kind of in the evening time. They ended up putting him on some antibiotics because they thought he may have strep. I think the rapid strep did come back negative, but they were thinking that it would culture back out, so gave him antibiotics, sent him home. They did do a white blood count, I think on that day. Called back Wednesday morning to tell Mom that that white blood count was super elevated, and that they needed to get him to the emergency department for further workup. When he came to us, he was very pale. He was tachypnic. His oxygen was 89 to 90% on room air. And he was just in a lot of pain. He could not move. He could not bear weight. And it was just super sad. We did complete labs on him, CT scans. In the ED, his white count was over 400,000. He was transferred to St. Jude's in Memphis. They tried to Leuka reduce him there, and that was, late Wednesday evening, I think, is, when we were pretty sure, telling the parents that he had leukemia. They sent him out, and Friday he died. So less than 2 days of a leukemia diagnosis, and he passed away. So that kind of stuck with me, and he was just a sweet 13-year-old who just had a whole life ahead of him, and so sad for the family and sad for him. And it's a case I definitely will not be forgetting anytime soon.